I'm going to start off with you actually, Bogdan. You know, the UK is a fair way along in terms of social prescribing and social connection. Has having a Minister of Loneliness made any difference at all? Do you think that Australia should have something like this that would help accelerate the driver of change at a policy level? Could you comment on that?
Absolutely, a brilliant question. In fact, and we recently visited the Danish embassy in the UK, received a learning visit around loneliness as well, and they were discussing the exact issue. I think it's had a huge bearing because it's really consolidated the pathway, and it's seen social prescribing as one of the interventions for loneliness and for connecting others, and it's really taking it more seriously. And to be completely honest, when social prescribing became policy as part of the UK's government approach, I think many people will know this because it received a lot of criticism, but the evidence wasn't there. If you looked at the evidence behind social prescribing in the UK at the time, the evidence wasn't there. Yes, it was in a way because of the things social prescribing was rooted in terms of person-centered care, shared decision-making, physical activity, the power of art in health, and the things we know work. But because it was a new concept, it didn't have the backing of evidence. And so that goes a bit against anything I've seen in terms of policy being accepted as part of the government's approach. But being part of that loneliness response was crucial. And the stories and the rallying of people getting together behind the movement, I think really pushed it. There was some campaigning done that you may know across the UK when the new minister was appointed, and social prescribing was seen as a crucial intervention. And I think it's slowly also being recognized in the need for deprescribing too. Loneliness is what it started with, and I can see it move now slowly to the agenda of deprescribing, especially in light of a big report in England done by the chief pharmacy officer to say that at least 20% of the drugs we prescribe in hospital are useless, and more so adding actually to the poor health of patients and side effects. And so I think it's slowly also pushing on that agenda. But yes, in short, it was a huge move.
Thanks very much, Bogdan. That's a nice segue into the hospital-based approach, Daniel. Would you like to sort of share with us how hospitals, hospital-based clinicians, and also primary care and community care-based clinicians can help promote this need for psychosocial health and wellbeing and social connection? Because I know you're doing some great work with your integrated care model.
Yeah, thanks, Judy. So I think it does come down to an appreciation that not everything has to have an organic, if you like, approach to management. And we've, you know, we learned when I was in medical school about the psychosocial approach, but I think that the psychological hasn't really sort of filtered through to the usual care pathways for especially hospital patients, which is a very artificial environment. There's a lot of potential harm in hospitals, and a lot of people, especially with chronic diseases, who readmit, it's often not due to the underlying organic problem. It's due to some other factors, and often those factors do relate to social and wellbeing and environmental things. And so we work very closely with a sort of a group that are called HARP, and people in certain locations might have this concept. It's called the Hospital Admission Risk Program within Alfred Health, and a lot of it's sort of a interface between primary care and hospital care, where we can really have a coordinator, a nurse coordinator is our model, who would, if you like, sort of help manage patient navigation, ideally in the community, but also be able to escalate up, you know, back into the hospital system, or try and transfer care back to primary care as much as possible. But look at, you know, the needs, the educational needs, and the social needs for patients, while they're sort of transitioning from a more acute care process to hopefully more stable care. So I think that there's options there, and I think there's options for collaboration with other stakeholders who are interested in this area, and whether they're sort of clinically trained or otherwise, and I think and linking with primary care, which is you know the ultimate goal as well. Yeah.
So how do we make it business as usual? How can we encourage hospital administrators to sort of get their clinicians to actually think about social connection? You know, I've done a lot of research and work in the emergency department at the Alfred, and you know, I followed a large cohort of 1,000 ED patients post-discharge, and loneliness was a key to that. How can we incorporate a simple measure, even a one-item measure, to sort of as part of that baseline assessment when they're sort of looking at what the presenting problem is, because we know there are lots of other issues as well as the medical reason, just to sort of say, hey, think about this person, so we can actually start triaging people to social connection activities post-discharge as part of that care transition.
So I mean, my opinion is I think it would need to be, I think we need evidence that, so we can speak the same language as people in the health systems that are seeing patients, and have it, you know, in whatever way we would sort of try and improve quality and safety approaches. So whether there's a checklist approach, whether ease of access is going to be important. And then the stories and having that you know, communication of outcomes with colleagues, but also normalising it, elevating the concept, reducing any stigma associated with loneliness. I think all of those things are critically important, and as important as you know, being able to measure a vagal venous pressure or read an ECG. You know.
Absolutely. So Michelle, you don't need to tell us that promoting social connection improves health, but we know it's really complex and it requires a global commitment across sectors, alongside focused evidence, which is something ELT is doing. How are you, with ELT and Loneliness Together, working to progress a coordinated national strategy?
I think, just building on Daniel's point, I think the word loneliness is a very stigmatized term, as many people point out. But actually, the less we speak about it, the more difficult it is to kind of put it in our normal lingo. That actually, we already know that preventing or addressing loneliness early can prevent future health problems. But the fact that we don't talk about it is an issue. It's very similar to what we went through as psychologists, you know, back in the 90s, talking about depression. Nobody wanted to talk about it because they were worried that people got more depressed, and that didn't really get us very far. So actually, the word lonely, when I say that, shouldn't be seen as dirty or something that's wrong with you. And we already know that loneliness is a consequence of a multitude of factors, all the way from policies to our environment. It's not about someone's personality. And back in the 90s, that was really what the research was doing. And the fact that social media and the media has kind of added to the misconceptions of loneliness, that, you know, someone who's lonely is the loser, and the person that's, you know, the depressive kind, and the person that nobody wants to be friends with, that needs to go. So that community awareness and the using the word lonely shouldn't bring up that feeling of there's something wrong. And I think that you know, my colleagues definitely in the UK talk about loneliness way more. And it's the word lonely isn't seen as negatively as over here. I mean, there's still connotations a long way to go, but they're way ahead of all of our other global countries that we work with. And the other thing is around sector training, even beyond the social prescribing, you know, is that perhaps, you know, we need this evidence-based framework that sits under every business, whether you're a corporate or whether you work in council, that we need to have social connection or a business model or policy models that encourage meaningful social connection. So not just the fact that we have these social opportunities to interact with people, but that building over time and nurturing those meaningful social connections within the spaces that we function. So in a very huge policy type, potentially systemic framework is really critical. And, yes, the evidence is super important, but we can do a lot of things that we know could encourage meaningful social connection as we go along and collect the evidence. And really, I really encourage all social prescribers and link workers to measure loneliness. I think often it's much more obvious to see the reduction in social isolation, but still a little bit more nuanced or more complex to actually measure loneliness. And there are ways that we can measure loneliness without that stigma, that a lot of the loneliness items are in fact indirect. But that should be the norm if that's really what we want to target. We need to really have that consensus language across everyone, beyond the social prescribing movement, to your GP, to your council worker, to your teachers. Can we teach children the importance of building meaningful social connection as they progress through life? So a lot of things to do, but we need to coordinate, and we need to have the same language, and we need to kind of work together, because this is not an issue that's just an ELT or Bolton Clarke or, an ADMA issue. This is all the problems that we need to solve together, which is much bigger than all of us.
So how do we do that?
Well, we need a coordinated response, and we need one voice to unite all sectors. Yeah, in which ending loneliness together hopes to achieve and hopes to do.
Do you want to talk a little bit about your parliamentary friends and what you see as a potential for Australian policy with that?
Yeah, I think Judy is kind of alluding to a national leadership roundtable that we recently held in the National Press Club. And despite the COVID restrictions and fears, we managed to gather the top national CEOs of both community and mental health sectors and the Department of Health. And I think what was very apparent is that we are all using different languages. We're not measuring what we're hoping to target. There's a lot of wonderful interventions out there that the potential hasn't been capitalized yet because of different issues. And I think that, the evidence-based framework that sits under a lot of them, and having one evidence-based framework is really very much needed. And around even policies around social infrastructure were things that were raised that were really critical to help us remove some of the systemic barriers to building more meaningful social connection. And really last thing, and just kind of wearing my hat as a researcher, what we do also notice is that, there's really a significant underinvestment in evidence-based research. So there are wonderful programs out there that almost never get widely implemented because of a lack of funding or difficulty getting sufficient funding. So often they stay in the ivory tower and they might get to an RCT, but there's no wide implementation to have an effect. And we know those are evidence-based, but they never get implemented, which is a real shame. So it's really encouraging the scale up of effective interventions and being able to measure and monitor them and tweak it if it's not as effective, to tweak it, and if it's effective, to share it. Those things are really super important.
Absolutely, and something that we're doing at Bolton Clarke is we've developed an implementation framework which we're actually applying at the start of all our projects now, so that we can actually work out what all those barriers and enablers are to implementation before we get started, so that if things are effective, we can implement them into business as usual.
I just wanted to add that actually what one of the other things that we did find, and which we're trying to rectify right now, is that people don't know where to go. This is not just for social prescribers, but being able to find places of connection, opportunities for connection, is something that people want, but it's not there. So we have decided to build a social connection portal that will be delivered in about 3 months. So if you are a link worker, you can register your service so that people can actually locate you on the website. And it's really powered by Info Exchange, which has all the services that you could think of by postcode. But we found that people didn't know where to go. And this is something that we're trying to reduce, that if we have groups or people who need to connect, whether you're a GP or someone who's helping a family member or someone who's lonely themselves, where do you go for help? And that's something we would like to kind of help bridge that gap as well.
Fantastic. If I could go back to you, Bogdan, with your early work as a student, where do you see us working with the student health workforce and any other workforce, really, because it is everyone's responsibility, and how we might go about that to try and normalise loneliness and, you know, empowering people about social connection and the vitality of that on our health and well-being?
I'm glad you've asked this. It's one of my favourite questions because I'm deeply passionate about it. Michelle touched upon this, and so did Daniel. It's about the wider culture change for me there. I think I love to play a game. I didn't try this with you all because, as I said, you're the converted, you know, preaching to the already converted, really. But I think I usually like to ask people the first word that comes to mind when you say the words health or healthcare. And sadly, I've done this times and times again with hundreds of medical students, even as a social experiment in public with the general public, and people throw at you words such as doctor, nurse, illness, surgery, pills, so on and so forth. And I think there's something that we got deeply wrong over the years around the definition of health. If you Google healthcare, you'll be inundated with pictures of stethoscopes and blood pressure measurements and ECGs and, you know, rushing off to do CPR and those kind of things. If you also Google healthcare definition, sadly, the WHO 1948 definition is not what comes up first. It's a dictionary definition saying it's the absence of illness. And so we proposed, or the WHO proposed, a definition in 1948, which is much more than that, yet we're still not there in 2022 with it. We can see we're not there yet when work experience students, school students, not even medical students, come to you in an interview and they say the reason why they want to become doctors is because they drilled a hole in somebody's knee and they saw some blood, then they took some bloods from someone, and they tell you about these fantastic practical things, and then in your mind you're thinking, but that's not what medicine is really about. It's about the person in front of you and about the 80% of their health that's being influenced by more than just biomedical, by social determinants of health. Yet we don't translate that into action, and we don't teach school students to come in and proudly talk about that. They instead talk to us about the exciting stitching. So I think my mission is to get principles such as social connection, to get people to recognize loneliness and be excited about it as they are about stitching and suturing and about those famous immunotherapy drugs that you hear about, make it as attractive for the young students as well. And I think that comes with our sphere of influence. It starts with each and every single one of us. It starts with the way in which we teach those around us in a formal or informal environment, which is why I like the word champion, which could sound cheesy at times, but I think we can all really start to change the narrative and shift that a bit to show people that this is an upfront investment that we're making in here. If we do focus to make a root change at the root of the problem where it's all started, you may not be successful in 5 years or 7 years, but then you will have a whole new generation of healthcare professionals that will deliver a completely different healthcare system and a completely different approach, one that recognizes social and psychological support for patients more than it does now. There's also something around Daniel's point earlier around what can secondary care do, and I think we're often very eager to blame the system sometimes and say that our hands are tied, and I've found myself countless of times in that position in the A&E department. You just don't have time navigate or to push the system when you're being pushed yourself from the time perspective as well. However, if you do see it as an upfront investment, and I think if you try and build some of those key points around to work with discharge coordinators, and we've seen pilots in the UK of clinicians working with discharge coordinators to bypass a bit the GP in the community and make the referral from hospital to the community so that it doesn't go as an extra workload letter to the GP anymore, then that patient will be picked up within the community. The GP is informed, but the referral has already been made, and then they can be picked up in some of those areas of opportunity. And of course, not to mention, I'm not going to go into this, but it's about that 360-degree support within the community and building the necessary funding at a hyper-local level. So central pots of funding we found in the UK to be very, very valuable when empowering local, hyper-local community groups, even if it was grants of £25,000, £50,000 given centrally to several groups across the UK. And an example of that is the Thriving Communities Initiative that you can Google and find out on our website. But there's been 50 grants given to groups across the UK in less favourable backgrounds, and they've done wonders to tackling health inequalities in the poorest boroughs across the UK.
On that note, with funding, Bogdan, do any of the local communities think about adding things to council rates, adding a levy on something so that the community is actually starting to contribute to its own activation and its own social connection? Has that happened at all in the United Kingdom?
That's starting to happen, and also to involve a bit the public and I guess the private sector as well, and starting to look for I guess the model of central pots of funding has always been good because you get the private funders. I'll give you some examples. For example, Arts Council England, or the respective bodies around the Big Lottery Fund, and several other organizations that could create central pots of money. Locally as well, the private sector is playing a role, but also local community groups as well. What we found very difficult, and this is just sharing some honesty, I think, around the language used. I think politicians sometimes run the risk of saying they're using the local community. And I think that's such bad narrative that should never, ever be used. You are enriching the local community and supporting to widen its horizons. You're working with them, not using any of it. If it is to work, you can't really use the local community or the voluntary care sector. It needs to be supported with funding from you before you use it. And so I think that's some very dangerous language there we've had many times before, and I know people have been upset by, but I think it's a recognition to say that needs to be developed and be put in place locally, because without it, it's not going to happen, is it? We need those opportunities. And I guess Australia also has fantastic support within the local community. So does the UK. We've really hit a roadblock when we talk about the US. And I know there's another conversation today, but the US being so commercial and different as a healthcare system, social prescribing being implemented there in terms of social connection and loneliness is very hard to do because of the lack of the infrastructure and the business model that operates there.
Yeah. Fantastic. Well, before we wind up the panel, Daniel, have you got anything else you'd like to say and give a plug for about what we can all do? Because it's everyone's responsibility. We have to invest ourselves in this to help everyone invest in it. Absolutely.
Look, I'm actually really increasingly inspired by this discussion. So yeah, look, this is becoming more and more business as usual for us in terms of my day-to-day activities, and I think we've got a lot to learn from Bogdan and the UK model. So I hope we can continue to connect, Bogdan. It's really great to hear your thoughts there, and I think, Michelle, as well, we probably need to link up with ADMA website and make sure we're not duplicating sort of things, because yeah, no, I think that's one of the things, keeping everyone on the same page, making sure we're sharing resources, and just having an energetic group of people that are interested in all this. It's really inspiring. Well, thanks for having me.
Great. Michelle, what would you like to say in your closing of this discussion before I hand over?
I think we have a couple of gaps that we've identified, and I have mentioned some of them before. But I think that just really to sum it up is really, first of all, we really need to invest in good scientific research and kind of leading away from market research kind of work, because loneliness and social isolation are complex issues, and they have a lot of confounding factors that we do have to understand the contributing factors of these constructs on health. We do need to build sector training, whether it's within our community, in our workplaces, in our schools. There's something that needs to be done in a methodical way and to really equip everyone so that we can actually ensure that social connection is a part of business as usual. And then we really also need to strengthen communities, whether it's about talking about it or equipping them to help people who are also lonely around them. We need to teach them skills that they don't require trained professionals to be involved. There are skills and strategies we can activate in people that can actually promote meaningful social connection. And the last, which is very difficult to do, but really requires a whole government approach around that, implementing evidence-based policies to really support meaningful social connection in every part of our society. So that's my four. I think that hopefully people can kind of take away today.
Thanks, Michelle. And Bogdan, your closing comments?
I think I've already spoken quite a lot, so I'm going to keep it very short and sweet and just put myself out there and the team in the UK, and just to say, please use and abuse us as you see fit. We would love to connect. As always, we see it as an amazing opportunity to share and spread the learning. Do join the evidence call if you're free on the 29th of March. Do get in touch about the Global Alliance and let's share what works. We have to learn a lot from you. It's not that the UK has it all sorted. I promise we don't at all, actually, and there's a lot of mistakes that we've made along the way, and hopefully we can share some of those as well as the things that work. So please do feel free to get in touch. I will send, as I said on the chat, some fantastic young medical students and doctors from AMSA in Australia, who I'm sure would love to connect with you all. And I think my final thought is think long term. Think culture shift and culture change that starts with a bit of the future generation, and get them to see that that healthcare does start within homes and local communities, not as we position ourselves in white-coated experts with pens lined up our sleeve and telling people what to do. We know that doesn't work, and we know when that happens, it's too late. We could have done many things before then. Thank you so much for having me, and lovely to meet such a vibrant panel, and thank you for chairing as well, Judy.
Thank you very much, and thank you, panel.